All right, I'm going to start it. We have enough people here. Welcome to the Wednesday conference. I'm going to talk about pain. And I guess if you guys can't hear me, somebody should just text me on my phone. Um, but this is a companion piece to my lecture about a year ago on itch. And back then, Maxwell Ma thought it was a joke. So we'll still see if this could be a joke that's a sequel and continues for a whole year. Um, I I kind of wanted to introduce myself, and I thought I would do it was an introduction that I've used quite a bit, but I was just going to continue it and just talk about some of my objectives. Here we go.
When the last light warms the rocks and the rattlesnakes unfold, then rush the sea forever across the silent sand, and the stars will be alive, and the wind will be my hand.
All right, so what is pain good for? And I'm here to talk about a little bit of the gospel of pain, just because I think pain's been given a bad rap. So so pain is good. It defends our body against damage. Um, One of the things that I would talk about was about in February. I was playing basketball at the IMA, and my knee went one way and my body went the other way, and I experienced the most excruciating pain ever. And at that moment, I had two thoughts that came into my mind. The first one was, one, don't cry, and the second one was, two, don't pass out, because that just wouldn't look good. So what that pain was telling me was that, one, I shouldn't be playing basketball at that moment, and two, I shouldn't be playing basketball against people half my age. So pain in that sense, and twice my height, as Dr. Swanson says. So pain was good. It would defend. It's the purpose is to defend your body against damage. But there's time when pain mutates and becomes something that is an entity in itself, and it's bad. But pain is fundamentally a neuropathic process. You need nerves to experience pain, and so that's I think where it becomes a neurologic process. Is that pain can only be conducted if there are nerves that are there. There's an exquisite signal to noise ratio, and the filters are the neurons, the spinal cord, and the brain. And so I'm gonna take the next few slides to talk about this signal to noise ratio, as well as the pathway, what are the filters that mediates pain. And so for the signal to noise ratio, here's the signal to noise ratio for like a radio, and you have it in different frequency, and the wanted signal that you want is much larger than the background on the bottom. That's the noise, and you want your wanted signal to be above that, because you want to be able to distinguish things that are just kind of innocuous touches or even pleasurable touches. How do we distinguish something that's pleasurable versus something that's painful? And the body is really designed, the nervous system is really designed for the pain signal to be really painful, to not be something that is just kind of painful. So I'm going to talk about how central nervous system is designed for that. The central nervous system is designed to amplify the wanted signal while decreasing all the noise. So what is this pathway? what is the pathway of pain? So it starts out in the brain, it goes into the midbrain, the medulla, and the spinal cord, and the skin and the muscle. And we're going to go from the skin, and we're going to head on back to talk about just the different regions and how do you localize pain. The pain fibers are in the skin, but they're also in the muscle. They go into the spinal cord where they synapse on a secondary neuron that goes up the lateral spinal thalamic tract, and it goes to the thalamus, the ventral medial lateral part of the thalamus, and the ventral posterior lateral part of the thalamus. And then there it synapses onto a third order neuron, and then goes to the insular cortex and the somatosensory cortex. So I'm going to focus on the skin here. So here, what happens at the skin and the pain receptors. The pain receptors are very much arborized, and they just pierce the epidermal dermal junction, and these are the cutaneous C fibers. And you also have the muscle group 4 fibers, which really are not diffusely in the muscle fibers, but they're really only on blood vessels. Some of them are on the perimysium, but mainly it's the blood vessels where you have that. So if you push down on, let's say that if you put a needle into this area, you really technically are not going to feel much pain. The pain really comes from the signals of the cutaneous C fibers as well as the muscle group 4 fibers. Now these fibers here, as a lot of people know, are unmyelinated, but the interesting thing is that even though they're unmyelinated, they don't have the wrapping, there are Schwann cells that cover them. And here you can see a little bit more of that process. So here is the skin. Once again, this is the epidermal dermal junction, and here are the small C fibers that pierce through, and you can see these little boutons here that are the pain receptors. Here is a blood vessel, and you have a nerve coming down, and it comes across here, the axons, and it synapses on the blood vessel. This is in the muscle of, I believe, a cat. Here is a human muscle, and here's the blood vessel. The yellow fibers are basically a combination of a Schwann cell marker as well as a nerve fiber marker, and you can see that they are just surrounding this blood vessel here. All right, so I wanted to focus a little bit more on these boutons here, and here's a graphical representation. So they have one Schwann cells that cover them, and it's really just one. There's no wrapping. This is at the end of a pain fiber, and there are varicosities. Here you have these things that we'll talk a little bit more about them, but this is really what like a free nerve fiber looks like. There's the nerve fiber, there's some exposed axon, but there's also a Schwann cell, one Schwann cell that kind of covers it. So how do we sense pain? What are the receptors of pain? And here are some of the receptors at the end of a peripheral nociceptor. And the things that cause pain are protein degradation products and protons and ATP. So what happens is either the protein degradation product activates this receptor called TRPA1. Pressure activates the TRPV4 receptor, while protons activate TRPV1 and ASIC1 and 3. It's interesting. ASIC1 is a very primitive sodium channel that mediates cardiac pain, and that's the receptor that seems to mediate pain when you're having a myocardial infarction. A big transducer of pain is ATP, and it activates pirinergic receptors P2X3. And if you give animals a antagonist to the pyrogenic receptor, that actually decreases the pain. All right. So then what happens when you activate them is sodium comes in and activates it. This signal then activates these two sodium channels and propagates the signal. These sodium channels are tetrodotoxin sensitive sodium channels as well as tetrodotoxin resistant sodium channels. And this causes an activation of the signal, and the signal goes both ways. It goes to another synaptic bouton and releases substance P and calcitonin related peptide, and that can activate things. And so I just wanted to summarize this slide in a couple of the slides. So first of all, the sensors of pain include protein degradation products, acid, temperature, capsaicin, ATP, pressure. All of those things can activate sensors. The second thing that I want to talk about is that pain is a two-way street, that the signal not only goes into the spinal cord, but it also goes and activates other synaptic boutons. And the release of substance P and this calcitonin related peptide is that it activates other synaptic boutons and other peripheral nociceptors, and that activates other pain receptors to fire, but it also activates the blood vessels, and sometimes you get this axon flare. And I think that this two-way street, this this anterior grade transport of signal mechanisms, probably the reason why you see conditions such as complex regional pain syndrome, and that's probably an activation antidromically of the signal from the central nervous system to the peripheral nervous system to activate pain and to activate these pain sensors. All right. The next slide, I want to talk about genetic causes of pain. They've been doing a lot of genomic studies and found there's quite a few conditions, familial conditions, that can cause pain. And this includes mutations in the TRPA1 receptors, as well as the prototoxin sensitive sodium channels, as well as prototoxin resistant sodium channels. This includes mutations in NAV 1.7, which is SCN9A, as well as NAV 1.8 and NAV 1.9, which is both the sodium channel 10A and 11A. And it seems as though mutations in these channels causes decreased deactivation, and the signal perpetuates more, and a lot of these patients have pain. Also, mutations in SCN9A seems to be the genetic underpinning for erythromelalgia. All right. My next slide, I want to talk about pain sensors, and I want to talk about peripheral sensitization. And peripheral sensitization is the reason why a signal that may be innocuous, after a long while, it becomes painful, and that's because these peripheral nociceptors are more sensitized to it. And the other way to looking at it is that this is another way that there's a filtration system. There's a filter here that basically it's trying to ensure that the signal that's getting through is a real signal, it's a real danger signal. And so it's only if the signal really surpasses that noise, then that signal gets conducted into the central nervous system. And to make sure that that's wanted signal is above the noise, you have all these receptors that basically help out in sensitizing the pain receptor. And these signals are the TrkA receptor for NGF receptor, TrkB for the BDNF receptor. Bradykinin is a huge mediator of pain, and bradykinin gets, when it activates, it changes actually the receptor from a B2 to a B1 receptor, which is more receptive to pain, and that is another way of changing the sensitivity. Prostaglandin E2 receptor is also really important, as well as serotonin receptors are important. Glutamate receptors are also important in terms of they activate the sodium and calcium, and that makes these mediators activate this system a lot more. So the conclusion is really that, once again, peripherally, there's a lot of fail-safe mechanisms to prevent the unwanted propagation of pain signal. And it's really when you reach a certain threshold, does the system really design to conduct a signal into the central nervous system. All right. So the next thing I kind of want to focus on is the spinal cord and also the connection between the first order neuron and the second order neuron.
Can I ask one question?
Yeah.
With fibromyalgia, what percentage of them would have one of these genetic mutations associated with it?
Right. So the question is, fibromyalgia, is it caused by one of the genetic mutations? And there's no good literature on that right now. They looked at a European group and looked at SCN9A and found that a lot of them, at least for small fiber neuropathy or fibromyalgia, had that mutation. But that's something that I want to talk about in terms of the research questions. It's something that we're thinking about trying to answer here. Maybe not fibromyalgia, but small fiber neuropathy. Does that answer your question, Dr. Slons? All right. So I want to focus here on this connection. So for these, the C fibers come in and they innervate the neurons on lamina 1, 2, and 4 of the spinal cord, while the A delta fibers really innervate the third lamina of the dorsal horn here. And so we're going to focus on the connection between the peripheral nociceptor and the second order spinal thalamic neuron. So here, the group 4 fiber is the pepto-bismol colored fiber. It basically synapses on the spinal thalamic neuron that goes into the thalamus. And here, the main mediators of the neurotransmission is glutamate and substance P. So when you have just a normal signal and just it activates glutamate, that activates the AMPA receptor, which causes an influx of sodium, and that causes a signal to go through. And that's probably a signal that you get when maybe, I'm playing on a basketball court and somebody hits me a little bit harder and it's weak signal. But if this guy continues to hit me harder, what happens is there's a lot more signal that comes through. Glutamate comes out, and there's more glutamate that comes out. It activates the AMPA receptor, sodium comes in, but at the same time, substance P gets released, and the substance P releases and it activates the NK1 receptor, and that causes secondary messenger system to activate and changes the biology and the secondary messenger system of the NADA receptor. Because of more sodium influx, this sodium little ball here gets unplugged, and when you have glutamate that activates the NADA receptor, you have a bigger signal. And once again, what we're showing is that there's a sensitization here, that normally a signal just causes a weak signal, but if you have further signal, if you have the signal that's above the noise, that's a wanted signal, it causes secondary changes to this synapse and causes it to have more signal that goes through. My next slide was really for Dr. Ransom and shows that glial cells are potentially important. They haven't been proven in any human models to be important, but in mouse models they seem to be important. And they seem to be, when they activated, when there's damage to the neurons or damage to the axons, they get activated. The astrocytes or the microglia gets activated, and they release IL-6, BDNF, nitric oxide, TNF alpha, and prostaglandins, and these are all things that modulate this synaptic transmission. But the next slide is really another layer of this filter system, another layer of how the system is designed to push down unwanted pain signal. And I'm going to talk about inhibitory pathways. And they're inhibitory synapses, and these synapses have GABA and glycine in them. And when they get activated, they activate the GABA or glycine receptor and causes an influx of chloride. And this decreases the activation of the excitatory synapse. And we can see that these inhibitory interneurons are sometimes connected to the A alpha fibers, and that's probably why sometimes when people have pain, if they touch them in the same area and they put a different kind of pressure on it, it definitely can relieve some of the pain. And so there are inhibitory pathways that are from the periphery, and there are also inhibitory pathways that are from the sensory, and there are definitely inhibitory pathways that start in the periaqueductal gray, and they synapse either in the medulla, in the ventral or dorsal part of the medulla, and then they send inhibitory antinociceptive descending pathways down. And so I think what I'm trying to say is that there are multiple ways of inhibiting this signal, and it seems as though this signal of making sure that we have the signal to noise ratio being amplified is really important in the pain system. I want to go up further and talk more about the central nervous system and its reception of pain, and just focus on this, on the somatic, on the cortex. And there's a couple of places that are important for for understanding, for receiving pain. The main ones, as everybody knows, is the primary somatosensory cortex, as well as the secondary somatosensory cortex, the insular cortex, as well as the amygdaloid body are really important, probably for an emotional affective component of pain. And there's signals that go from the spinal cord up to the thalamus and then to those places. The anterior cingulate gyrus as well as the prefrontal cortex also participate in mediating pain and mediating just higher cortical responses to pain. So I wanted to kind of summarize this really complicated and this very basic view of pain into the following things. Sensors of pain include protein degradation products, mechanical pressure, protons, temperature. What I have not listed here is capsaicin and ATP. Pain, number two, pain is a two-way street. The signal is sent into the central nervous system, but is also sent towards the peripheral nervous system. And this could be the underlying mechanism for complex pain regional syndrome. Three, molecules mediating pain cause pain when mutated. There are definitely a lot of genetic data that suggests that these molecules that we talked about are important. In fact, one of the molecules that I haven't talked about, TrkA, when that is mutated, it causes congenital insensitivity to pain and anhidrosis. And these patients get mutilated because they don't feel any pain and they start to lose digits and arms and feet. The next thing, number four, is peripheral and central sensitization occurs to overcome the filters. The system is designed as a series of filters. And we talk about sensitization, and I think the reason why we have it is really to amplify the signal and to make sure that the filter system works. And probably different people have different filter systems. That seems to be different in different people, and that's why some people are more sensitive to pain. But peripheral and central sensitization occurs to overcome the filters. Number five, inhibitory antinociceptor descending pathways, as well as pathways from the periphery, add to the filters. Does anybody have any questions here? All right. So,
Can I ask you a question?
Oh.
Did you talk about this at the beginning about the old Milzak and Wall's theory of gating of pain?
No, what is, I didn't talk about the gating of pain.
So that's what I was going to ask you, how that fits into these paradigms. There's this old theory that, Phil, tell me if I'm wrong about this, that you have cutaneous fibers that if they are overstimulated, if they're stimulated, that they can block other cutaneous fibers, like C fiber, like A delta fibers blocking C fiber.
Right.
So that was a theory that Melzek and Walls put forth, I don't know, 40, how many years ago?
Long time.
Long time. So Dr. Swanson says it's a long time. It's probably pretty long.
So this gating is really from the periphery, is that right?
And it's a theory, so it's not, I don't think that there's ever been any acceptance of that as a fact, but the question is, does it fit into any of these paradigms that you're discussing? I'm just
right.
curious.
I think I illustrated it here. Dr. Weiss is mentioning the gating theory of pain, and I think this is kind of similar in terms of the A delta fibers coming in and synapsing on a inhibitory interneuron, and that inhibits the C fibers from transmitting signals to the spinal thalamic tract, and that's a gating theory. And I think that was I didn't. What's the name for that again?
Well, it's I don't know if it has a name. It's
gate theory.
Oh, gating theory.
Yeah,
Melzak and Wall's theory. So the theory behind why if you hit your hand and you rub it, you can get it to feel better because you're stimulating other cutaneous sensory fibers that block C fiber.
Right.
That was my and it sounds like it does fit into this paradigm.
So I didn't speak of that specifically, but I was talking about in general principle of how the whole nervous system is really designed to make sure that we suppress unwanted pain signals, and that gating theory from Milzak and Walls is probably part of that. And I think that it has been proven in animal models. All right. So when is a neuropathy painful? And that happens when there's loss of epidermal nerve fibers. And here you have, once again, the dermis and the epidermis, and you have these small fibers that pierce through. And when you have loss of these, like here you can see that when there's loss of these small neurons, that's when you have a neuropathy, at least the small nerve fibers, and you sense pain. And here you can see it also in muscles as well. And this is courtesy of Amir Dori and Glenn Lopate of Washington University in St. Louis. And it's from one of their papers. And here's a blood vessel and muscle. And you can see here's the small nerve fibers that are innervating the blood vessel. And here they're again, once again, surrounding this blood vessel here. And when you have a neuropathy, they're trying to illustrate that there's fewer neurons, there's fewer small nerve fibers that innervate the blood vessel, and here there's fewer of them. And that's probably, I think that's probably why a lot of patients with fibromyalgia, small fiber neuropathy experience muscle pain, because all these signals from the muscle as well as the skin, they go and synapse on the same spinal thalamic neurons. And so that's why our experience either is referred or it's from both, and it's a very diffuse kind of dull pain, probably because there's decrease in these fibers, as well as that these fibers in the muscle also innervate the same nerves in the spinal cord. So that's why pain seems pretty diffuse, and it seems it's in the muscle. Another thing that we're going to talk about in a little bit later in the talk is about how there's quite a bit of patients who don't have these abnormal changes on the small nerve fibers, and that may be because it's a patchy process, or maybe mainly the decrease in the pain fibers are mainly in the muscle, are in these fibers, and we're not capturing them. So Dr. Krause has a question.
Why would you have more pain if you have the absence of pain fighting? Must be something different going on.
So Dr. Krause asks the question that will be answered in the next couple of slides, in terms of why would you have more pain if you have fewer nerves? Very interesting. So this is my hypothesis, and I'm going to illustrate it with something I stole from Wikipedia, of course. So I think that this is what's happening to our nervous system. We have all this noise, and some of this might be, pleasurable touch. This one is probably pleasurable touch, and you just kind of leave that alone, and that's not experienced as pain. And then when you have something like me twisting my knee, that becomes a wanted signal, and it goes through. And what happens in a peripheral neuropathy is that all of these signals get decreased. All of these signals get basically squished down. The wanted signal and the noise gets decreased. So you have a loss of signal to noise ratio in the periphery. And so when this is happening, the brain is not getting enough signal. The brain is saying, I am not feeling danger. I don't know what's going on. I really need to make sure of that. And you have it basically tries to amplify the whole signal. And this is what happens in the central system, is that it basically tries to amplify both the wanted signal as well as the noise, because it's trying really hard to make sure that it gets the signal. And at a certain point, this noise overcomes that threshold in the brain, and it causes the brain to sense it as pain. And there's definitely a lot of examples of the brain amplifying signals and making sure that it gets enough signal in. And you get that with tinnitus as well, in terms of they've done MRI studies and found that the ringing in the ear is not, there's actually no ringing. It's the fact that there's lack of hair cell signals coming into the central nervous system, and the brain starts to substitute this ringing in there because it's trying to amplify the signal. You also get that with people who have hallucinations, with visual loss. With the loss of vision, the brain starts to invent signals to come in. I think the same process is going on in the central nervous system. And so what's happening is that you have a lack of these nerve fibers, and that didn't work out. So you have a lack of these nerve fibers, and there's fear of these signals to come in, and the signal that is used to be innocuous just becomes even stronger, and that's how you sense it as pain.
Why not as an alternative, if you have nerve fibers that are not functional, or maybe there's some reinnervation and they have, they're hyperexcitable. Why couldn't peripheral nerve hyperexcitability be an explanation?
I think that peripheral nerve hyperexcitability can be an explanation, but I think a lot of the patients that I see definitely have a sensory loss. So this seems to be there's decrease in a number of that. I think that's hypersensitive excitability is definitely a reason where you can have reinnervation and arborization causing that. And also you can have reinnervation and that causes the two-way street and the release of substance P and that activates more of the remaining neurons. I think those are definitely possibilities. This is all in the realm of conjecture.
Why a lot of the medications, neuropathic pain medications that are sodium channel blockers, that might explain why there's this group of them that seem to be block sodium.
Dr. Weiss is mentioning that sodium channel blockers seem to be effective in blocking pain. How have you had really good experiences with carbamazepine and mexiletine for this kind of pain?
Mexiletine is making a comeback. I haven't used it very much, but the pain clinic folks are starting to use it more and more, even though the data is based on some older studies.
Yeah.
But even gabapentin has some sodium channel, part block sodium channels. A lot of the other anticonvulsants probably have. So they have other mechanisms of action. But that's one mechanism of action that might unify all these different neuropathic conditions to some extent. Seem to be reasonably effective. Of course, that could be in the central nervous system too. They're blocking stuff.
I think that for the tricyclic antidepressants, they're really blocking the serotonin in the spinal cord and the thalamus.
It's mostly the anti-epileptics or the anesthetics.
I haven't had really great experience with anti-epileptics for mediating pain. And there hasn't been that great data for using the anti-epileptics, except for pregabalin and gabapentin for pain. Definitely for topiramate for diabetic neuropathy, it hasn't really been found to be useful. So they're definitely not my main line for treating pain. You had a question.
So if the brain isn't getting enough signal from the peripheral nervous system, could you increase the stimulation so that it doesn't upregulate the nervous system? So could you have increased sensation or pressure or something like that?
So I guess the question is, since we have decrease of these fibers, if we increase the training of the fibers that are remaining, will that also decrease the gating or just the sensitization? And I don't know.
It's kind of like if you
Right. You create more noise with that. It doesn't seem to be creating more noise and touching my patients more doesn't seem to make them better. So I'm not, in terms of like doing it in the human population, that doesn't seem to be the answer in terms of just putting more pressure on it. I think that
Transcutaneous stimulation.
yeah, but do you think that's how it's working?
I think that sort of get back to the Melzack and Walls idea. You're gating pain.
Right. I don't know, but I think that everybody's probably going to be different. All right. So what causes painful neuropathies? Age, genetics, and environmental factors are the main components of what causes painful neuropathy. And in genetics, we talked about the sodium channels, the NAV 1.7, the NAV 1.8, and the NAV 1.9, as well as the TRPA1 receptors. Environmental factors, protective factors are things that keep you active, and non-protective things are the really known ones: diabetes, chemotherapy, probably antibiotics as well as probably inflammation and stress. So diabetes, it's in 8.3 to 8.5% of people in the Europe and United States. The prevalence of neuropathy and type 1 diabetes is 10 to 54%. At 54% is probably a little bit high. For type 2 diabetes, it turns out to be interesting. A lot of patients at the time of diagnosis already have neuropathy, a painful neuropathy, and that's about 8%. And there's definitely a substantial number of patients in which the first presenting symptom is neuropathy in type 2 diabetes. So you definitely can discover diabetes in your neurology clinic. The overall prevalence of diabetic neuropathy is about 21%. Idiopathic neuropathies, idiopathic painful neuropathies, or sensory predominant neuropathies. The prevalence is about 2.4% of the population, 8% above the age of 55. And it seems to be multifactorial, related to age, genetics, and environmental factors. And I guess the question is that, for people who have developed painful neuropathies, is this a neurodegenerative disease of the sensory neurons? So that's kind of the hypothesis that I'm going to propose and incite some discussion. So
You mean age, like an age related?
no, I'm not talking about age-related sensory neuronal loss. I'm talking about mainly a painful neuropathy. And could that be for idiopathic?
Like a small fiber, like a degenerative process of small fiber
Yeah.
sensory neurons?
Yeah. I think I'm trying to see if anybody else will buy into my theory that maybe this is a neurodegenerative disease of the sensory neurons that we're seeing throughout the nervous system. And here's an example. Here's a brain MRI. Here's a woman who's in her 20s, and here's a gentleman who's in his 70s. So we're losing neurons just throughout. We're losing them in our hearing cells. We're losing them in our brain and in the central nervous system. So why shouldn't we be losing them in our peripheral nervous system? So the question is painful neuropathy a neurodegenerative disease of the sensory neurons? And this is a different way to conceptualize this problem, but we'll see if you guys buy it or not. So if you look at epidermal nerve fiber density of the leg, here's the fibers per millimeter. This is looking at a really 3 millimeter plug of skin and counting the number of epidermal nerve fibers, so counting the small nerve fiber. And here you have it over age. You can see that if you put in a logistical regression, it decreases over time. And so there's definitely seems to be a decrease in the number of these fibers. And so the way to conceptualize it could be that the number of neuron decreases with age in all of us. This is just a normal process. But if you have a genetic process, say you have certain genes that make you more predisposed to this, that they will then die off sooner and they'll cross the threshold in which they will cause pain. You have environmental factors, say you add on diabetes or the fact that you were exposed to chemotherapy, you'll have this quantum decrease of these nerve fibers. They kind of go down at the same kind of speed, but at a certain point, the same slope, but at a certain point they're going to reach a pain threshold and cause pain. So do we see that in our population? Do we see that in our population of patients? And we have we've done about 220 skin biopsies here at University of Washington. And here is the foot epidermal nerve fiber density. And we plotted it against age here. And you can see
you couldn't go that way or that way.
It's not
right. I think this is really, I totally agree. I think this is really random. This is what Excel told me to put on. So it's not, I didn't do that. I think, I don't know. Definitely in our data, it looks fairly random if you ask me. But the other thing that you want to think about is that the assumption is that all of our patients, hopefully all 220, we didn't do it just for chuckles, that we had a high suspicion that they have small fiber neuropathy. So keep that in mind, that this might not be truly representative of the general population. Here's the data when we plot it out for the calf intraepidermal nerve fiber density, and here's over age. And here you see a better slope that's downward trending. But remember, these are our population of patients who we have suspicion that they have a small fiber neuropathy.
How do you determine the density? I mean, is that by eye?
No, they count the number. So
Who's they?
They is this company in upstate New York, a pathology company. They take this small plug of skin.
You take a biopsy, you send it off to New York.
Yeah, because our pathologists don't do it.
I'm not repeating that comment.
It's true. They never wanted to do it.
So what happens, Dr. Swanson, is that we take this small plug of skin and we send it up to upstate New York, and a lot of labs do it, and it's a fairly common procedure. They take a slice through it. They take about a 50 micron slice, and they count the number of small nerve fibers that pierce through the epidermal dermal junction, and they do that at the calf and at the foot, and also at different various sites. And then they report out what we have here. So I'm plotting here. Here's the people that were normal by by the skin biopsy. These were deemed to have normal values, and here are patients who have abnormal values. And you can see that in the foot, some of them have pretty. The number is usually around, I believe, around 6 is the where it becomes no, it's about 4. And these numbers above here are patients who, like the blue ones, were determined to have a small fiber neuropathy by skin biopsy, and probably because the calves were abnormal. The calf side was abnormal, and that's how they were determined to have small fiber neuropathies. But you can see once again that it's spread out pretty wide, and there's definitely some patients who were found to have loss of small fiber nerves in the calves or in the thighs to have pretty normal foot intraepidermal nerve fiber density. This could suggest that it's a very patchy process. It could suggest that this is a ganglionopathy and non-length dependent process. You can basically spin it whatever way you want.
Do you always biopsy 2 places then?
Yeah, we always
Sort of
They always
biopsy.
to see if it's like.
You can biopsy 3 places.
You can do the hand or you do foot, calf, thigh, or
I had a patient who had one done on his scrotum.
Is there normative data for that?
There's no normative data, and nobody volunteered for that. But it supposedly was very abnormal. There was a lot of fewer cells.
A neurologist did that?
I did not participate in that. He had it done with a general surgeon. Had to go through anesthesia. Yeah, like Dr. Weiss said, there's no normal value, so it's probably not a good site for it. Here's the calf data. Here's all the abnormal ones. There are definitely some that have pretty normal densities, and here's the normal. This regression line is really for our normal populations, the patients that we determine that they're normal by skin biopsy. There is some decrease in nerve fiber density, so there's definitely decrease, but it's definitely not as prominent as what was reported before. Here, where you see there seems to be, and this is a normal population, so probably in a normal population you do see a decrease in that.
So when you have a decrease, if you have a more proximal lesion, let's say it's in tabes or ganglionopathy or something like that, will you see distal changes?
The question is, if you have a tabes or ganglionopathy, would you see changes in the peripheral peripheral skin biopsy? And I think the answer is yes. But the problem is that it was a really patchy process.
Because I think the only value you could do atypical sites if you have an abnormal, if your person has abnormal sensation on one side, normal on the other, you might get some useful information by doing both sides. So having that as an control, still you good normative data. Sure of that.
It sure looks a lot of scattered. That you just wonder how.
Oh, I think your point is that this is very random, and I think that's absolutely true. And so the question is, how do we make this better? And I think that's what we're hoping to talk about. So the epidermal nerve fiber.
Well, I was going to say looks like you could almost create your own normative data from the scat. You could use make your own cut points.
I don't know if we can, because so the question is that can we?
You could like do it at 4.5, because you can affect sensitivity specificity, but you probably have pretty high sensitivity, pretty high specificity. If you did that, I don't know if that's the same value that.
For the calves, they have now new data that suggests that it's an age-related normative value, so it does go down with age. So it's different, but I would really caution to use this data for normative data, because all of these patients, we're not biopsying normal patients, and we shouldn't be biopsying normal patients. So all these patients have some sort of painful condition, and so I'm not so sure this is the population that I would determine a normal value. And so
how was the other population determined, though? Were they truly normal?
Right. All right, so I'm told that I need to wrap things up.
Sorry.
So here at UW, our results are that we had 205 cases, and our normal value, we had 56% of them normal, abnormal was 44%. While at Therapath, with the company that we use it at, they had 15,000 total cases, and there were 44% that were normal. So we have definitely more patients that we're analyzing that are normal. You can also look at count sweat gland densities, and we've done 66 here at University of Washington, and our yield is higher. We have 32% of abnormal. So for us, it seems as though the sweat gland density might be more abnormal than Therapath. So small fiber neuropathy, this speaks to Dr. Swanson's question, has been found to be useful, has been found to be maybe the underlying cause of fibromyalgia and ICU pain. So small fiber neuropathy, the annual incidence is about 12 cases per 100,000 for small fiber neuropathy. The incidence of Guillain-Barré is 0.89 to 1.89 cases. The incidence of CIDP is both of these are much lower than small fiber neuropathy, and the diagnosis, in my point of view, is very clinical. Its diagnosis is based on the presence of at least two of the following symptoms not otherwise specified: neuropathic pain, burning, shooting, or itching, the feeling of not being able to tolerate bed sheet or sock, restless leg syndrome, autonomic dysfunction, Sicca syndrome, accommodation problems, hyperhidrosis, hypohidrosis, micturition disturbances, impotence, or diminished ejaculation or lubrication, bowel disturbances, hot flashes, orthostatic dizziness, cardiac palpitations. Also, clinical signs of small fiber damage, including pinprick loss, thermal sensory loss, allodynia, hyperalgesia. A normal nerve conduction study reduced interepidermal nerve fiber density at the ankles, and you have abnormal quantitative sensory testing for thermal thresholds at the foot. And for patients who have small fiber neuropathy, these are the symptoms that they have. If you have definite of them, a lot of patients report burning, tingling. Those seems to be my patient population as well. Numbness. A lot of them have a length dependent. Most of them have all of them have a length dependent process. Some of them are worse as walking. Some of them have diminished toe vibration. A lot of them have diminished pinprick in the toes and feet. Diminished temperature in the toes seem to be a more sensitive test. A lot of them have allodynia and hypoalgesia. So small fiber neuropathy and fibromyalgia. There's one paper that looked at 6 out of 20 consecutive fibromyalgia patients, and they found small fiber changes on skin biopsy. Another one looked at 25 patients and found that 25 out of 25 of small nerve fiber involvement, but not all of them showed reduced epidermal nerve fiber density. Some of them probably had sweat gland nerve fiber density that would change. Another study done in Boston showed that there was a 41%. So definitely small fiber neuropathy seems to be a reason why, could be a reason why a lot of fibromyalgia patients have pain. Now, not all of them have it. How can you explain that? Well, you can explain that by the fact that this is a patchy process, or by the fact that this is a process that maybe is affecting more of the muscle nerve fibers more than the skin nerve fibers. The last thing is that I wanted to talk about is critical illness small fiber neuropathy. And they did one and they looked at 14 patients. 13 of them had infection, sepsis, or multi-organ failure. All of them had severe non-life dependent loss of the intraepidermal nerve fiber density. Sweat gland innervation was reduced in all except one patient. And of the 7 patients available for follow-up, 3 complained of diffuse sensory loss and burning pain, and another 3 complained of clinical dysautonomia. So what I was talking about how this potential neurodegenerative disease could have age, genetics, and environmental factors, I'm proposing that an environmental factor could be trauma, or it could be critical illness like sepsis, infections. On top of that, these are very complicated patients because they're also been exposed to antibiotics. So that's really the gist of this talk. And so for people who have more work to do, it's 12:55 and you can go. The rest are really more for discussion and more for research questions. And so for the research questions, and this is something to talk with our group, are the following. It's like, what are the genetics of painful neuropathies? If we sequence patients with SCN9A, how many of those patients in our patient population in Pacific Northwest in the United States will have mutations? And another thing that we were talking about was a group in Arizona is to do exome sequences and to look at a different number of genes and seeing whether those are mutated in these painful neuropathies. The problem is that we're going to really need a lot of patients for that.
A lot of money.
And Dr. Swanson says a lot of money. And another question is, how do we maximize our skin biopsy yield? We only have in our population, it's about 43% of them are abnormal. So how do we maximize our population so that we have more, that the yield of the sensitivity of the skin biopsy in our hands are higher? So the questions that we could ask potentially in our population of 205 patients is the positive skin biopsies related to pain level? Is it related to some of the physical findings that we're talking about? And so maybe if they don't have a really high level of pain, if they don't have physical findings on neurologic exam, maybe we can say that a skin biopsy probably won't be useful. So that's something that we can think about.
Do you know about a correlation with the QSART tests?
So I think there are some correlations between QSART and small fiber neuropathies, but there's a big overlap, but it's not always.
But the 205 that you looked at, we don't know their QSART results.
The 205 patients that we looked at University of Washington, I believe that most of them we don't have QSART testing on. And that would be actually really interesting to look at the patients that were normal by skin fiber biopsy and whether they had QSART finding and how much of an overlap it is. So that's definitely a project that we can talk about. And maybe Dr. Distat will talk about it at her grand rounds, which is the last grand rounds of the year. She's just reminded that she might have to give grand rounds. And another thing that we were interested in is the ICU neuropathies. I think this is a great model for environmental causes of neuropathies. And one of the things that we were thinking about doing was the ICU pulmonology group here is look at ICU patients with or without pain at follow-up and seeing whether they have decrease in small fiber nerve densities. And this would be important that maybe for some of our patients who have ICU pain syndromes, that a clinical trial of amitriptyline may be better for sleep, and it might also be better for treating their pain. So this is really my second to last slide, and it's about references, and this is a shameless plug for my own chapter. It's coming out in Bradley's Neurology and Clinical Practice. The 7th edition is not out yet, but you can look at the older 6th edition and read up a little bit about it. And then I thought this book by Mency and Gerwin was great. It's called Muscle Pain, Understanding the Mechanism, and that's a great book. I believe it's available online. You can download the PDF, but I'm not so sure about the legality of that. If you have any questions, you can email me, or you can, I guess you can write me.
Write you a letter.
All right, thanks a lot, everybody.
So I think you need some controls. Isn't that one of the problems? And you're just doing these biopsies and things, and people have got complaints. So I've had diabetes for 20 years. I'm old, so you want to do some studies on me?
Oh, let me do it. Let me
We'd
do
be
it.
very happy to.
I mean, don't you need some controls?
Well, we're
So-
using other people's controls.
Yeah, we're using controls that Therapath has done, and and there's definitely controls that have been published quite widely. Justin MacArthur at Hopkins did a study where they looked at normal adults, and he was looking at small fiber neuropathy in HIV population. So he has a set of controls. Therapath also has a set of controls, and they've been changing it, and they've also changed it now to have age-matched controls. So there are definitely controls, but we'll definitely think of you for a candidate for.
Well, I know.
Did you just say Dr. Swanson's out?
I don't have any.
I heard
I don't have any
Yeah.
complications
I
of
don't have any
diabetes, but
Sure.
I've had it.
Sure.
By
So the real question, Dr. Swanson, is: are you willing to stay some time in the ICU, and then we can?
well, that'll come, I suppose.
All right. All right. I'm gonna just see if there are any questions from. Oh, there are a few questions.
Do you think that the same patient would have a different number of neurons that you could count in different regions that you biopsy, and you're just missing?
Right. So a question here is this process patchy? And absolutely, yeah, it could be patchy. And
So we would need normals for any other area that we tested.
Kate's saying that pain gating things involves A beta, and that's possible. I remember it being A delta, but my senses is probably not incredibly well worked out, but it's probably both fibers are involved. And Mike Kim says, does spinal cord stimulation affect central processing sensitization and therefore explains his potential benefit for neuropathic pain? I think that's a really good point actually, in terms of maybe that's another point in trying to work on making sure that the brain gets stimulation. I don't know how you would test for that, how that could be a hypothesis, could be tested, but it seems as though spinal cord stimulation is helpful in neuropathic pain. I don't know if it's helpful for all neuropathic pain, but for Mike, I think the question that you should ask really is if deep brain stimulation, since it's effective for depression, whether it's effective for pain. I think that's a question that you might want to consider, and you would be a very popular doctor here in the Puget Sound region.
The A delta are the